All right, guys, welcome back to Underground Science. In this video, we'll be talking about IgA deficiency. All right, so let's go and get started. So the basic pathophysiology of this, right? In patients with IgA deficiency, they have a problem with making IgA antibodies, right? So what happens is they have proper B cells, right? But the thing is, remember, we class switch, right? We class switch. The B cells can class switch. So what this means is, right, we have defective class switching of the B cells. Remember, when you have an infection or some sort of pathogen that gets encountered, right, by your immune system, when your T cells get activated, they can release cytokines that help your B cells to class switch. And then they class switch into things like IgA secreting B cells, IgE secreting B cells, IgG secreting B cells, and so on, right? But the problem in here is people with IgA deficiency, their B cells cannot class switch into producing IgA. Okay, they can still class switch they can still class switch into B cells that produce IgG and IgM, but not IgA. So they become IgA deficient. Okay, so why is this bad though? Why is it bad to be IgA deficient? So let's go and see that. So first, before we talk about that, we should see that in most cases, IgA deficiency is asymptomatic. And why? Because, okay, if you are deficient in IgA, right, IgM actually can partially compensate for mucosal defense. Okay, that's why it could be asymptomatic in most cases. But if you do see symptoms, what would we see, right? Well, remember, we said IgA is important for mucosal defense. Well, where in the body do we have mucosa, right? So the lungs would be one. So IgA deficiency, you could see an increased risk of respiratory infections, right, leading to pneumonia. And some pathogens that we're familiar with, right, that can cause this would be things like strep pneumo, right? Strep pneumo or Haemophilus influenza. Even Haemophilus influenza can cause this too. Let's write this down. And even things like Moraxella catarrhalis, right, as we know, can cause pneumonia, right? So those are some pathogens that can lead to pneumonia in the respiratory tract due to deficiency in IgA antibodies, right? Because you need IgA antibodies in your mucosa. And then we see mucosa in our lungs, right? Our respiratory tract. So if you don't have proper amounts of IgA, that could lead to pneumonia, okay? Or respiratory infections. Now, another place where we have mucosa is our GI, right? Our intestines. So if we don't have IgA there, then we can see infections there, right? Which we know Giardia can cause infections in our GI tract, right? If we have deficiency in our IgA antibodies, certain enteroviruses can cause that too. Even Campylobacter can cause infections in our GI tract, right? So another one to be familiar with is, oh, what was that? Campylobacter, right? Campylobacter jejuni can cause infection in GI tract also. So those are the main areas, right, where we would see infections or increased risk of infection due to IgA deficiency. Now, remember, because this is relating to our immune system, it can be associated with other autoimmune diseases, like celiac disease, for example, like rheumatoid arthritis, even SLE, right, or a inflammatory bowel disease, right? So these are the diseases that can be associated with IgA deficiency. Okay, and one thing to keep in mind, right, an important thing that you should be keeping in mind is when we're talking about blood transfusions, right? So in these patients, because they're very deficient, right, in IgA, these patients can develop anti-IgA antibodies. Now, these antibodies are IgE antibodies against IgA. Okay, so it's against the IgA antibodies. Because they're so deficient in IgA, they make antibodies against that. Just like, for example, right, if we're talking about blood types, if someone's blood type A, right, they're deficient in the B antigen. If you can you can think about it like that, right? So then they make antibodies against the B antigen. Just like that, if these patients are highly deficient in IgA, that can lead to anti-IgA antibodies, and those anti-IgA antibodies are IgE antibodies, and we know IgE antibodies are associated with allergic reactions, right? So if a blood transfusion occurs in these patients, right? In normal blood transfusion, right? In blood, it's normal to have small amounts of IgA in it, right? So if that happens, right, and they receive a blood transfusion, and we said that um, the blood that's transfused can have IgA in it, then of course these IgE antibodies can bind the IgA, right, in the whatever blood products that got transfused to this patient, and then of course that can lead to a massive allergic reaction, just like you would see an allergic reaction, but it can lead to a massive anaphylactic reaction, right? Because we know that mast cells, right, have IgE on it, especially when they're primed. So if you have a bunch of IgE here and this patient receives, and remember, this IgE is anti-IgA. Now, if this patient receives blood products, which is normal to have small amounts of donor IgA, then of course these IgE antibodies can bind onto the donor IgA, and then this can lead to massive activation of your mast cells, which will lead to degranulation. And we know mast cells release excessive amounts of histamines and glucotrienes, which can cause a lot of inflammation, right? Contribute to inflammation, swelling, edema, and anaphylaxis, right? So we know mast cells play a role in that too. So if you have anaphylactic reaction, right, you can go into shock, right? Anaphylactic shock. So you would see shock, you would see hives, right? Urticaria. Of course, you would see bronchospasm too, right? Because we know that's part of, if have an allergic reaction, we know that can happen, which is why EpiPens, right, are important in allergic reactions. So you can open up the airway to get proper amounts of oxygen into your lungs. And of course, in shock, we see low blood pressure also, right? So the basic idea is, okay, you can see anaphylactic shock here. So that's something to watch out for is in these patients, all right? So that's basically IgA deficiency, right? We should know that, okay, it's due to the fact that your B cells cannot class switch into IgA secreting, right, plasma cells or IgA secreting B cells, but it can class switch into IgG and IgM secreting B cells. So your IgG and IgM levels are normal, but you don't have any IgA, right? So in areas where you have mucosa, like your GI tract and lungs, you can get infections, right? And then of course we should know that IgA deficiency is related to other or is associated with other autoimmune conditions like systemic lupus erythematosus, right? SLE, like rheumatoid arthritis, like celiac disease, even inflammatory bowel disease, and so on, right? And then the last thing to make sure, right, keep in mind is that these patients can be at a high risk of a anaphylactic reaction to blood products transfusion, right? To transfusion of blood because these patients may have anti-IgA antibodies, which you said were IgE antibodies. And we know IgE antibodies can be bound onto mast cells. And if these antibodies bind to the donor IgA, you can have massive activation of your mast cells, which will cause a huge inflammatory response and things that you would see in anaphylactic shock, like bronchoconstriction, hives, and low blood pressure, right? And of course, we know massive histamine release can lead to edema and swelling too, right? So that's basically it for this video. That's IgA deficiency. I hope this video wasn't too confusing and I hope it helped a little bit. Thank you guys for watching and see you guys in my future videos.